All right, well, it's our obligatory 401, so we'll get started. It's my pleasure to introduce our Grand Round speaker today. Dr. Nasvin Imamudeen is obviously one of our second-year fellows. She received her MBBS in India before coming to Marshfield to complete her internal medicine residency training, and then did a couple of years in primary care before we were lucky enough to bring her to MCW. She's had a number of publications and was interestingly on the Bone Health and Osteoporosis Steering Committee at Marshfield. So certainly got a lot of bone experience there. But today is going to talk to us about PCOS and decoding the PCOS syndrome from adolescence to menopause. Nasvin, it's all yours.
Thank you, Dr. Carroll, for the kind introduction. Well, the day has arrived. So, as it's obvious, this is going to be a comprehensive review, as shown in my title. We have a lot to cover, so let's just get started. I have nothing to make. I wish I had. Objectives would be broadly to discuss epidemiology, pathophysiology, the complex pathophysiology involved in PCOS, kind of walk you through the diagnosis, screening, and prevention, and kind of discuss some relevant studies and, looking into the comorbidities associated with this condition, and kind of conclude with management. So it is the most common endocrine disorder in women of the reproductive age group, and diagnosis of PCOS could be considered as lifelong or enduring. It is a very complex disorder or syndrome, which has genetic and epigenetic influences and likely has environmental factors which just exacerbates the underlying pathology. It's characterized by endocrine changes, which is further exacerbated by BMI, which again is very prevalent in this population. It is characterized by free androgen levels as a result of functional hyperandrogenism, problems with the hypothalamic pituitary axis, insulin resistance, the compensatory hyperinsulinemia that ensues, and a variety of clinical manifestations which can broadly be categorized into reproductive, metabolic, and dermatologic, which we will be discussing. And the very underrecognized part of it is that, at least for me, up until kind of reading more into it, I underappreciated how much of a psychological burden these women carry, and they come with a lot of problems with body image issues. It's associated with eating disorders, and some studies have shown 40% of these women have a diagnosis of depression. So I think it's important to highlight that. So again, this kind of depicts the life course of a woman in PCOS. As we know, many of the symptoms start at adolescent age group, and then it peaks in the reproductive age. And while they attain menopause, many of the symptoms mitigate, but does it go away? Well, some of the hyperandrogenic symptoms could still persist. And what would be more clinically relevant would be to see more studies as to what that persisting hyperandrogenism would be doing in these postmenopausal age groups, but we don't have very many, but that's something that is gaining interest these days. What you see on the right-hand side is a disability-adjusted life years and kind of showing the disease burden of PCOS. The ones that's highlighted in the red and orange are the areas which are the most affected with the PCOS burden. As you can see, the United States, the North America, Central Latin America, the Northern Western Europe, southern parts of Asia, and Australia are the areas which are most significantly affected. Prior estimates of prevalence used to say the prevalence is 6 to 10%, but with better understanding of the disease and the evolution of diagnostic criteria, the prevalence is thought to be 10 to 20%, and a meta-analysis has shown a pooled global prevalence of about 22%. And in 2019 study, it showed that the USA disease burden was about 5 to 10 million. There is a lot of healthcare burden that's also involved, and mostly due to it comes from complications related to diabetes and pregnancy. as well as cardiovascular events like stroke. And unfortunately, in 1/3 of these women, the diagnosis of PCOS is delayed by 2 years, which greatly adds to the satisfaction of women in their care. With that being said, and that overview, let's move on to the pathophysiology and physiology. So to my current audience, the HPG axis is no stranger. So I would just focus on the red circle, which is kind of this later would help us better understand when I explain the pathophysiology. So the process of recruitment of the primordial follicle to the primary follicle is, kind of a very intra-ovarian complex process that's involved, where FSH doesn't have much role. From there on, FSH-mediated follicular maturation happens, and then to the Graafian follicle, and with the LH surge, the ovulation occurs. And the next picture depicts what happens in our theca cells and granulosa cells of the ovaries. So in the theca cells, the cholesterol is converted to androstenedione, and the androstenedione is converted to estrone or estradiol with the help of aromatase in the granulosa cell. Because I would later mention about the IGF, insulin-like growth factor 1 has a paracrine role, and it is produced by the granulosa cells in the ovary, and its function is paracrine here, which helps with steroid synthesis. So the first, and with that, I would like to start with one of the most expert groups, let's say, agree on the fact that women with PCOS have functional hyperandrogenism. There is an intrinsic increase in androgen production in PCOS, and it has been demonstrated. It's primarily ovarian and to some extent adrenal. The theca cells isolated from women with PCOS have shown that there's an increased intrinsic production in culture. However, in vivo, insulin and luteinizing hormone are the primary stimulators of androgen synthesis, and that coupled with an absolute increase in the theca cell number, which again could be due to an increase in follicle number and also an increase in theca cell thickness, which ramps up the androgen production. So on the top, you could see, the outer thinner layer is with the black arrow is a theca cell, and the inner layer is a granulosa cell. That's a normal ovary. And the one below, as you can see how the theca cells have within, that's a PCOS ovary. So the androgen biosynthesis, this functional hyperandrogenism, is thought to have a genetic predisposition. And several genes have been implicated, but the most popular and most commonly is well recognized one these days and have been implicated in many studies is the DEND1A. So this was found in a genome-wide association study. And in 2014, it showed that a forced expression of DEND1AV2 in normal theca cells had augmented cytochrome P450 enzyme expression. And these two are enzymes that are helpful, are crucial to the rate-limiting steps in the androgen production or the steroidogenesis pathway. So another underlying mechanism in the pathophysiology is that women with PCOS are found to have increased GnRH pulse frequency. So in normal women or in normal persons, the GnRH pulse frequency is 1 per hour. In PCOS women, it's much higher. As you can see, it's normal, and this is the PCOS pulse frequency. So a higher pulse frequency of GnRH favors LH versus FSH. So a higher level of LH in turn would act on theca cells and ramp up the steroid production, steroidogenesis, and there's a relatively lower FSH. Also thought to be involved in the pathophysiology is, again, GnRH needs kisspeptin, and the kisspeptin that comes from the KNDy neurons, there is also theories that it starts there, which in turn causes the increased GnRH pulse frequency, and there are thoughts that the increased anti-Mullerian hormone levels circulating in women are also playing a role because there are AMH receptors in the hypothalamus. At the level of ovary, The LH action is enhanced in PCOS ovaries, as well as there is an upregulation of the LH receptors. And all these with the local modulators like the insulin, inhibin, IGF-1 tend to ramp up the androgen production. There is impaired folliculogenesis in women with PCOS. So for reasons that are not well known, there is recruitment of a large pool of early developing follicles, and the greater AMH levels per follicle all do not favor the FSH mediated maturation, and many of these follicles get recruited but does not complete their cycle and get arrested at different stages. And this depicts a picture of several antral follicles arrested at different phases in the mid stage of development. So this is a PCOS ovary. Another important mechanism in the pathophysiology is that of insulin and its action. So there is some intrinsic insulin resistance in women with PCOS, which is at least partly BMI independent. The steroidogenesis obviously remains insulin responsive, but there is systemic insulin resistance, and the compensatory hyperinsulinemia favors androgen production because it enhances the receptivity of the ovarian theca cells to LH and the adrenal zona reticularis to the ACTH, and hence ramping up the androgen production. The several insulin receptors and downstream pathway are also involved in the dysregulation, and there have been studies that showed adipocytes in women with PCOS are aberrant in their morphology as well as function. And one among the several is a decreased production of adiponectin. Adiponectin is usually an insulin sensitizer, so a decreased adiponectin could cause increased insulin resistance, which through several downstream pathways cause hyperinsulinism, causing hyperandrogenism, and then this is a vicious cycle. So having probably confused you all enough, let's move on to the diagnosis, screening, and prevention part. So I think it's important to know a little bit of evolution of the criteria. So this was first reported, the first polycystic ovarian syndrome was reported in 1935 by Stein and Leventhal, who reported 7 cases of patients with amenorrhea, infertility, and who had multicystic ovaries. And over the years, the criteria have evolved. In 1990, the NIH came up with their criteria, which required hyperandrogenism and anovulation, with or without polycystic ovaries. That was not a requirement. In 2003, the Rotterdam consensus criteria was that they included the polycystic ovaries, and at that time, it's important that numbers have changed. The follicle count per ovary was 12 or more, and 2 out of the 3 needs to be satisfied. The Androgen Access Society and the PCOS Society in 2006 came up with their criteria where hyperandrogenism needed to be the feature, and the other 2 could be one of the others. So, but hyperandrogenism was one of the core features for making diagnosis based on that criteria. And then in 2012, there were extension of the Rotterdam criteria where they added phenotype. And in 2018, the International PCOS criteria came out, which is essentially the Rotterdam criteria, but they've increased the ovarian number of follicles per ovary, especially now that several years have passed. Ultrasound techniques have become more sensitive, and so they've changed the cutoff. And now in 2003, 5 years later, after 2018, the International Evidence-Based Criteria got updated, and the Rotterdam Consensus is now grounded in the international guideline, with one change that they've made, or one addition, which is the addition of anti-Mullerian hormone, which could be used in place of ovarian ultrasound. And I'll talk about it in a subsequent slide. So we have to be careful with the adolescent criteria. Ultrasound or AMH levels cannot be used in adolescents because, one, there is no definitive criteria, and this population could normally have higher number of follicles and higher AMH levels. So I think there are several definitions for irregular menstrual cycles, but for the population of women that we would see, anything less than 21 or greater than 35 days for duration or less than 8 cycles per year is defined as irregular menstrual cycle. For clinical hyperandrogenism, as we know, hirsutism, acne, female pattern hair loss, all are clinical symptoms of hyperandrogenism. However, hirsutism is most specific. So in the PCOS population, about 80% of the women just present with hirsutism, and the prevalence of acne is about 40%, and that of female pattern hair loss is about 25 to 30%. And we have to use a modified Fairman-Galway score of 4 to 6 to detect hirsutism. The range is because there is ethnic variations for the score. And with the advent of newer technologies with epilation and hair removal techniques, it is difficult practically for us to look at a patient and assess this, but this is something that they can assess. So I think a practical thing that I have done when I was in my primary care practice was I had a sheet which showed this, and the patients would self-assess. So I mean, that's one way that I see we can implement it. So biochemical hyperandrogenism again is by measuring a total and free testosterone. Free testosterone is recommended to be measured along with total. As we know, there is hyperinsulinemia in PCOS, which can decrease the production of SHBG. So the total testosterone can look falsely normal, and hence a free testosterone using a reliable assay like LCMS is recommended to be used. If the total of free is not normal, you could consider measuring androstenedione or DHEAS, but noting their poor specificity and the age-related decline. The definition of polycystic ovarian morphology is that of 20 or more follicles per ovary, and it's the antral follicles, the 2 to 9 millimeter follicles are the ones. And we, I think, rely on our radiologists to give us a good interpretation. Or an ovarian volume of greater than 10 ml could also be used. But when we look at the volume, it is important to omit those dominant follicles or cysts or corpus luteum that are greater than centimeter, because otherwise it can overestimate the ovarian volume. So I think that's something that if we are in the habit of looking at the ultrasound, something to keep in mind. And these are not recommended in adolescents. So the AMH levels, and it's good that they added it, but they never came up with a good cutoff. And I mean, we can't blame them because it's based on population and assay-based cutoffs. I was talking with Dr. Narins today. The best evidence that I could come from in different studies is that what they used as a surrogate for ultrasonographic detection of PCOM is a 3.2 nanogram per ml. And that rather looks like a low value, but here the upper cutoff is 6 to 8. So yes, we do have this as a tool, but at this time, I cannot see a practical way where we could implement in our current practice. So it's something that we need to come up with, our lab-based cutoffs. So at this time, I can't see a practical utility, but that's it. And the important things that would affect the AMH, there are several factors, but age and recent or current oral contraceptive pills are the most relevant ones. Recent or current oral contraceptive pills can tend to reduce AMH levels. So PCOS is a diagnosis of extortion, so it's important that we explore things that can mimic PCOS, including non-classic CH by getting a 70-hydroxyprogesterone level, prolactin levels, TSH, and also if something is not typical, usually in these women, they'll have a lifelong history of slow, gradual symptoms. If something is not looking, if something is abrupt or sudden, then you should have a higher suspicion for other ominous causes and work up these women as needed, as appropriate, and if screen for other conditions like Cushing's or acromegaly if and be warranted. So based on that, the diagnostic algorithm would be if somebody presents with amenorrhea and clinical hyperandrogenism, you essentially have made the diagnosis. You need not do biochemical testing for demonstrating elevated androgens, but you need to explore other causes. However, if only irregular menstrual cycles, then you go ahead and do biochemical testing. And if that's yes, you've made the diagnosis. And if you only have irregular cycles or hyperandrogenism, then that's where you go to the ultrasound or the image level. And adolescents who are in this spectrum, you cannot make a diagnosis, but they have to be reassessed once an adult, usually 8 years post-menarche. So screening and prevention, regardless of age and BMI, we know that these women have an increased risk of impaired fasting glucose and type 2 diabetes. Even women with normal BMI have a higher prevalence of insulin resistance and dyslipidemia, and hence metabolic screening is of utmost importance. Weight, BMI, waist circumference, and blood pressure has to be measured every visit. Practically, I don't do waist circumference, but these women are at increased risk of central adiposity than generalized obesity, central obesity that they have. So if practical, it's recommended that be done. And for glycemic testing, OGTT is preferred over fasting glucose and A1C and a dyslipidemia screen. So why OGTT? A recent systematic review has shown that when a cutoff of 6.5 was used for, it missed 50% of women with PCOS who had diabetes. So if practically not possible, I think at least it's important, especially these women who come to us who desire fertility or who are seeking fertility treatment, at least for them, kind of encouraging them to do an OGTT because, realizing the higher risk of hyperglycemia and the associated comorbidities in pregnancy would be important. So the frequency of glycemic testing, a position statement of the Androgen Access Society says, if normal glucose, consider testing once every 2 years, if abnormal, annually. For dyslipidemia, no clear guidelines or recommendations. Do it at first visit. Everybody agrees to that, but then the subsequent frequency of testing could be anywhere from 2 to 3 years or more, depending on the other cardiovascular risk factors. Now let's move on to the comorbidities. So already discussed partially, 40 to 80% prevalence of obesity in these women. The development of overweight in PCOS could start as early as below 5 years of age, kind of depicting demonstrating the early onset of the syndrome. And there are ethnic differences. The highest weight is usually found in African Americans and South Pacific Islanders, and the Europeans and Southeast Asians have lower BMIs but higher central adiposity. So metabolic dysfunction, 50 to 80% of women have insulin resistance, and they are at a fourfold increased risk of type 2 diabetes. By age 40, at least 45% of PCOS women would have either impaired glucose tolerance or type 2 diabetes. Dyslipidemia at age 31, according to a study, has been shown to be significantly associated with diagnosis of PCOS, and their serum triglyceride levels remain significantly elevated independent of the BMI. The metabolic dysfunction-associated steatotic liver disease, or the MASLD, a meta-analysis showed that there is a 43% increased prevalence of metabolic dysfunction, MASLD, in these women. And the potential mediators are, kind of obvious with this, the metabolic syndrome, and the increased insulin resistance is evident by increased HOMA-IR, which is a surrogate marker for insulin resistance, and elevated free androgen index and circulating testosterone levels in these women. However, going back to that a little bit, there is no current guidelines as to whether we need to screen these women for SLD. The endometrial cancer risk is 5-fold elevated, and that's probably due to the chronic anovulation, the progesterone resistance, local progesterone resistance, overweight, hyperinsulinemia, and there's also low-grade inflammation. Now, having talked about all those risk factors, up until recently, we do know that these women have a lot of cardiometabolic risk factors, but whether these translate to actual cardiovascular events, I think that's a more relevant question. So this is a very interesting study from a Northern Finland birth cohort, 1966. So what they did is people with an estimated birth year of 1966 had been followed from birth. At age 31, they were reassessed, and they were compared. They were diagnosed with PCOS either using the NIH criteria or the Rotterdam criteria, and then they were compared with their controls. And several parameters have been checked at the time, which I wouldn't go into details due to the interest of time. And at age 46, they were again re-examined, and they were followed up until age 53 for major adverse cardiovascular events, which included MI, stroke, heart failure, and cardiovascular mortality. So as you can see, there were 144 NIH-PCOS women, and there were, around 400 Rotterdam PCOS women. What was interesting is that the cumulative hazard curve started deviating at 35 in both NIH-PCOS women as well as the Rotterdam PCOS women. The hazard ratios were 2.33 and 2.47 for them. So, and we have data up until age 53 for these women. Among the actual CVD endpoints, MI was more prevalent in both these groups. So I would be interested to see when these women is followed over the years up until their late postmenopausal groups, how these CVD events evolve. So that's yet to come. And the recent meta-analysis involving 27 studies and more than 1 million women showed that there is an increased risk of composite CVD. I've not included all the forest plots, but as you can see, there's a 1 point that says 1.768, so almost 2 times risk of MI, composite ischemic heart disease, and cardiovascular disease. However, cardiovascular mortality was not reach clinical significance. Was not able to demonstrate that. So I never used to think about obstructive sleep apnea. I mean, a woman who was overweight or obese, if they come to me, yes, I could think about it. But it is also shown that even women with lower or normal BMI are increased risk, and several studies have shown that. This is one of the studies which, again, as you can see in adults, the odds ratio was almost like 10 times, and then for adolescents it was almost 4.5 times, or almost 5 times, and taken together there's an increased risk of 8 times the risk as compared to control. So that is relevant, and hence the international evidence-based guidelines now recommend, it's an EBR with a moderate quality evidence that we should screen these women for OSA with using validated screening tools. So management. Lifestyle is the cornerstone but that not lifestyle alone, but lifestyle is the cornerstone of treatment. It is shown that at least even 5% body weight reduction can offer metabolic and possibly reproductive benefits in this women. So anything that works for them, there's no specific diets. So whatever is sustainable has to be recommended, and exercise. The combined oral contraceptive pills remain to be the first line treatment in women with PCOS because they target hyperandrogenism, menstrual dysfunction, and also provide additional contraception. Lowest effective dose of estrogen, which is defined 20 to 30 micrograms of estradiol, should be used. And there is no clinical advantage of using a higher dose over a lower dose. And at this time, no combined oral contraceptive pill is superior to another in treatment for PCOS patients. And we would follow just the general population guidelines and discuss the absolute and relative contraindication. And there's no specific recommendations in this population. This is a table that shows the different types of progestins and their VT risk as well as their androgenicity. Norepinephrine seems to have the right balance of androgenicity and the VT risk, but these are the most commonly used progestins with estrogen that's available in the CUSP form. The International Evidence-Based Guidelines as well as the Androgen Access Society 2018 guidelines for hirsutism do recommend to maintain caution when we prescribe OCPs for women above 40, as well as those who are obese. But that's the predominant population that we see. But the benefits far outweigh the risk in this population. The endometrial protection is also of utmost importance. So if somebody is on COCP, that gives enough endometrial protection. But for some reason, if they do not want to take a COCP, then progestin-only preparations should be considered. It could be in the form of IUDs. It could be in the form of cyclic progestins. But in some form, they need to get some form of endometrial protection. So in terms of metformin, Metformin alone could be used in adults with PCOS and BMI if we are focusing on the anthropometric or the metabolic outcomes in these women. And it could be considered to be used in adolescents as well for cycle regulation, but we don't have very good data, but there is some limited evidence. It could, with acknowledging the limited evidence, we could also use metformin in women who are not overweight. Whatsoever, it has no effect on hirsutism, and that's something that we need to counsel this patients if they expect their hirsutism to improve. It will not. The potential to restore menses in a dose of at least 1 gram per day has been shown in a study. This is a little complex study, but I would like to draw your attention to the green dotted and solid lines. So this is OW stands for overweight and NT is normal testosterone. So there were 4 groups who were studied, and what they looked for is how menstrual frequency improved, and also looked at how the testosterone levels and BMI have changed with the 6 months of treatment, and they were followed up until like 24 months. The overweight normal testosterone group showed the highest proportion of patients with restoration of normal menstrual cycles at the end of 2 years of treatment with metformin. So it's effective. Anti-androgens, again, to treat hirsutism in women with PCOS, if there is a suboptimal response to combined oral contraceptive pills, it's important to counsel these women. It'll take at least sometimes up to 6 months once these oral contraceptive pills are started to see some improvement. However, if a woman comes with a lot of psychological burden of their disease, and you could consider using combination therapy, but that's not first line to use combination therapy with anti-androgen and COCP. And it's important to counsel them on an effective contraception when using anti-androgens. And if in the event of pregnancy, it's important that they get counseled on the under-virilization of male fetus when an anti-androgen is used. Commonly used ones are spironolactone at 100 to 200 milligram per day are effective. And Endocrine Society clinical practice guidelines gives a BID dosing, and it might be due to the fact that it's a half-life, and I couldn't find any literature that explained well why that is. Others are finasteride and flutamide. The Endocrine Society clinical practice guidelines for hirsutism does recommend against use of flutamide because of its potential hepatotoxicity, but I was talking to Dr. Sarvedio the other day, and we use it knowing that the absolute risk is less, but that should, that conversation has to happen with the patient, because if they are not having any improvement in their hirsutism scores with other anti-androgens, it's okay to try. So, inositol. This is an herbal supplement. It has made its way to the international guidelines. In the 2018 guidelines, it was considered as experimental, but now they say you could consider using it. So it's available in 2 forms, myo-inositol or D-chiro-inositol. It's any form could be used. So reading a little back into and kind of curious to know like what are the effects of it. It's widely abundant in the fruits that we eat and a lot of plant varieties. The inositol incorporates into triphosphate inositol, which is important, which is an important messenger for many hormones, including insulin and FSH. And any defects in this pathway can cause insulin resistance. So that's kind of the, a little summary of how it works. So this is a study of 30 trials. It's a systematic review and meta-analysis, which was conducted, which compared the MI as myo-inositol and DCI as D-chiro-inositol. So what they showed is, or what was seen in the study is that myo-inositol improved SHBG levels, and as you can see, and the combination of myo-inositol plus folic acid, FA is folic acid, and folic acid alone, when compared, the HOMA-IR, which again is a surrogate marker for insulin resistance, there was improvement in insulin resistance with myo-inositol, and here with the DCI or the D-chiro-inositol, the ovulation rates improved. So very low side effect profile, natural supplement. So where I practically see this being used would be a woman who does not want to take anything, metformin, no COCPs. We know that there are some benefits, but very low quality evidence. So that's something that we can have a discussion, but it's made its way to the guidelines. So the studies on GLP-1 analogs and PCOS are very sparse. We don't have very many. This is one of the randomized control trials that was done with 3 milligram liraglutide versus placebo. So Novo Nordisk gave these people, a very identical pens, and they were followed for up to 32 weeks. So as you can see, not surprisingly, there is significant improvement in weight reduction in liraglutide as compared to placebo. That's about 60% of them achieved more than 5% weight loss, and this is PCOS patients. So they do very well as the other people with obesity. They are not more resistant. There's no studies to show that they are more resistant to weight loss. So their weight improved. More interestingly, the free androgen index with the liraglutide group has improved after 32 weeks of treatment. And the p-value was significant there. The menstrual cycle frequency, where they started off with less than 4 or almost 4 menstrual cycles per year, improved to more than 8 menstrual cycles per year. So that was also significant. So now this is yet another study, but a much smaller one, which showed that semaglutide, the dose of semaglutide used in the study was not very impressive. It was only 0.5 milligram per week, but it showed that 80% of them lost more than 5% of body weight, and 80% showed normalization of menstrual cycles. So fertility, it's important to counsel our women who with PCOS that there is no long-term data demonstrating that PCOS patients are more infertile than the general population. So after a long-term follow-up, there was no difference between PCOS versus controls in the proportion of women who had at least one child or who had at least one spontaneous pregnancy. But it might take time because of problems with chronic anovulation and may require some medical treatment for fertility, but they are not infertile because many of the women come with that concern that they might not be able to conceive. And under fertility, I thought it was very important to kind of mention the two landmark studies that we have. In 2007, where it compared clomiphene with metformin, or both for infertility. So as you can see, the clomiphene and the combination therapy had better rate of live birth. But when we compare clomiphene versus combination therapy, that was not very significant. And the most amount of weight loss was seen, live birth was seen in women with a BMI of less than 30. Later in 2014, the study where they compared letrozole versus clomiphene for infertility came. And there, letrozole showed, the letrozole is red, the red graph showed more cumulative live births, and the ovulation rates were higher with letrozole, and there were no significant difference in pregnancy loss or when compared, when both of them were compared. So now, and because of time constraints, I have not expanded, management of fertility to more than these two slides, but I would like to discuss and conclude this portion with a very interesting study that I came across which looked at bariatric surgery and fertility outcomes in PCOS. So we do know that there are medications that can help with fertility. We do know that weight loss will restore ovulation, and there have been studies that showed weight loss from bariatric surgery in PCOS women had restored ovulation. But whether it translates to actual pregnancy or live births, I think that's a more relevant clinical question. So there was this study which included, they looked at 216 premenopausal women, and then finally they came up with 49 PCOS and 120 control. So this was a retrospective cohort study. The cohort was the women who underwent bariatric surgery from the year 2003 to 2015, and they were followed up until 2019. What they saw is that as compared to, so you could see two different graphs because in each follow-up visit, they did ask for, at baseline and follow visit, they did ask for the desire for fertility. So they kind of, subgrouped into those. There were significant improvement in pregnancy rates in women with PCOS who underwent bariatric surgery as compared to their controls. And you could see, even though it did not reach significance, the values were not significant on there. The number of live births were higher, the number of pregnancy rates were higher in women with PCOS. So I think if this was demonstrated in a future randomized controlled trial, that would be a great study. But this shows that, there is, when we counsel our patients who are resistant to management with drugs like GLP-1, like how bariatric surgery could have some benefits. So in summary, I would like to emphasize that this is the most common endocrinopathy in women of the reproductive age group, and going through doing a thorough evaluation and exclusion of other causes by following a comprehensive, endocrine assessment. Knowing that functional hyperandrogenism and insulin resistance are core key factors in the pathophysiology of this condition, and the importance of screening these women for metabolic and cardiovascular disorders, including obstructive sleep apnea, and having a greater awareness that there are studies coming out that might be showing that the actual cardiovascular risk factors could mean that they are also having actual CV events. But more studies are to come on that. And it's important to individualize treatment and make effort to address patient-important symptoms in these group of people, especially who comes to us with a lot of psychological burden. And kind of going through the fact that lifestyle remains a cornerstone, with COCPs being the first line. So with that, I'd like to conclude.
So we'll open it up for questions, and if you're online, please feel free to unmute or type in the chat box. I guess I'll just start saying, great talk. I guess I'm just struck by how maybe poorly sometimes we do about complication screening. We talk about, glucose, and we've had this conversation about ATTs versus OGTTs, and OSA screening. I don't know if I've ever done that, like routinely thinking about it. How do you think we move to doing those things? Is it just being more aware of it, or what screenings do we really need to do?
Yeah, good question. I think at least now, if time allows, again, that's a big factor with, we discuss a lot of things with these women, and priorities being weight management and other more patient important symptoms, which usually are hirsutism and acne or whatever is that. But I think I'll be more mindful from now that they are at this increased risk of OSA, and at least I haven't done a good job, I should say, in explaining them that OGTT is the most preferred, and kind of walking through. I think making them aware and knowing that this is best, and if you don't do it, there's a chance that we could miss it, would be something that I would try to implement in my practice. And asking simple questions like, are you refreshed from sleep? Kind of the initial screening questions, even though we don't have the time to go through a full stop bang. I would at least do some basic assessment is what I'm thinking. Yes.
So are we supposed to be doing OGTT like every single, like we can't just do
the screening? So that's the thing, right? Like the screening, dyslipidemia, the dysglycemia screening has to be done at the first visit. So the subsequent visits, there is no data as like, would you follow the OGTTs or would you follow? So that's, again, if they are up to it, doing once a year OGTT, that would be, if their A1C or fasting blood glucose was normal in the first place, on a subsequent measure, it could still be normal. And if we detect the dysglycemia with the OGTT, I think that's what we should follow. But I don't have an absolute answer for that. But that's what I would follow.
So I have a little bit of an issue with all the guidelines.
Yeah.
There's guidelines, and then there are patients. Yeah. All roads lead to weight management, lifestyle management. So yes, all this oral GTT. So what am I going to do with it? Is my advice going to be any different? So I look at A1C, it's not there. So you're asking me to do oral GTT.
Mm-hmm.
So what am I going to do different?
So, and where I can think, what I can think on that for that question is that if somebody did an OGTT and that was abnormal, we could have the conversation of possibly, starting metformin.
I would maybe bring it up.
So,
I think sometimes, yeah, it might be easier to get GLP-1 insurance coverage.
I mean, yes, the insurance coverage, that's a different story, but I'm just saying, that's another visit, these are all often young women. So, the insurance issues, that's, if you get diagnosed, maybe it'll get covered, but in general, I don't really treat anyone any differently from a practical perspective. I still would say the same things to them.
mm-hmm.
And if that's how I look at it, maybe I'm explaining myself because I don't do oral GTTs.
So at all, is your issue with like the repeated, like, because they're saying you could do them intermittently, or is it with just even the initial?
So I would
sort of
treat them like, just like how patients with diabetes, you treat them as though they have cardiovascular disease. If I have a patient with PCOS, I treat them as full blown. They have whatever it is, all, you have to do everything possible. I didn't consider the insurance piece.
Oh, I guess that's why I do it. It's easier to get GLP-1 coverage. But I've never actually diagnosed dysglycemia with OGTT in anybody who didn't have the abnormal A1C.
So we know PCOS, they have so many, there are so many studies with inflammatory markers. They have high insulin resistance. So I would treat them like they have everything and, do all that advice to the fullest extent. That's how I.
One situation where OGTT would be, you might change what you're going to do, because I agree. I mean, Nasvin can, comment. Have this conversation all the time in clinic, and we end up doing an A1C. But I think the board answer is do the OGTT.
Yeah, no.
But a woman who is contemplating fertility, an OGTT might change what I do in terms of earlier screening and pregnancy. If they're borderline OGTT as opposed to just an A1C, I think that might be the time when that might actually change your management.
Yeah, I would think by the time, at least maybe they may not have diabetes on the A1C, but they may have. Yeah, I'm just kind of trying to.
Yeah, I mean, that's a good point.
GTTs, maybe
Yeah, we do know.
It's a burden. It's a burden to patients. Right. It's gross.
Yeah.
Disgusting. If you haven't tried it, you should.
Mm-hmm.
It's disgusting. Okay. And certainly it's a burden on patients because it takes a long time to do it. The folks that did the multidisciplinary PCOS clinic and fellowship at Madison, that was to the reproductive endocrinologist who's an OBGYN there. That was her point, was the catching even the earliest dysglycemic changes could change how aggressive we are with our screening for pregnancy and fertility and those types of things. But have I ever done it where I've done serial OGTTs? No. Gosh, no.
Yeah.
Because it's a lot of work.
And that's why we don't do it as often.
I will say what we did was what they did in the clinic is a lot of times you'd get kind of that, and then they're getting labs anyway, so you get it with an A1C, you get it with a fasting glucose. And you can track the A1C and fasting glucoses too over time if you're not seeing sort of early dysglycemia on the OGTT. So
I have one more question. So what are you going to tell a patient if they're going through menopause? What's going to happen to them in terms of, because the majority is ovarian androgens, right? So what happens after menopause to these women?
So
do they improve or not improve or worse? Because a lot of women, post-menopausal have actually hyperandrogenism, right? So now what happens to these women who have hyperandrogenism before?
So how do I approach treatment, or how?
There's 47, 48, they ask, what happens if I go through menopause? Are my hyperandrogenism symptoms, are they going to improve or not improve?
Well, postmenopausally, many of these symptoms improve, but there are women in the postmenopausal age group who could have persistent mild hyperandrogenetic symptoms like hirsutism. So how do we approach that? I mean, we could. I've seen, at least I've read people treating with OCPs at lower doses in that age group just to target the hirsutism, or you could use anti-androgens if that's a bothersome symptom for them. But if it has been present there and if they are not bothered by their hyperandrogenetic symptoms, I necessarily probably wouldn't do anything. But by the time, when they are in the postmenopausal age group, they might have accumulated other risk factors because of their, long-term obesity. And probably that's a population where I might be treating with, metformin based on what I see from their labs, but that wouldn't mitigate their hyperandrogenic symptoms if that's the primary concern. So I would think I would use something like an, anti-androgen in that group.
So I guess, I mean, the answer is we wouldn't know, right? So it depends on some patients, I would think, like, because I do get asked this question a lot, like, am I still going to have all this hair, after menopause? But I guess the data.
They do.
So some, if it's ovarian, what happens that's what I guess the question roundabout, what happens to that ovarian excess androgen production at menopause in patients with PCOS? I guess we don't know the answer to that.
It improves?
Anyone knows? It improves, or I don't know.
Because again, if we look back at the pathophysiology, there.
But then, your hair follicles are already all up and running for so long. So that's probably why they have persistent messages. And there was a study, maybe like 10 or a nice publication, that statins can also lower testosterone level, right? So that's
statins?
Statins, yeah. So look it up. That was there, very, very nice. I would say about 10 years ago.
Okay.
So in women of 40, 50 plus, if they have other risk factor, that's another argument for statins. Say, well, you may get some.
Yeah, it's interesting.
I used it.
And we have laser therapy. I mean, it's the best. Yes.
Yeah, does laser therapy work if there's underlying hyperandrogenism? Like, let's say.
Yes, because it acts.
It comes back.
Right.
So it's not
Several sessions.
you have spironolactone and it works, but it won't be permanent. Like if you treat the weight.
The frequency is different. The treatments are, but it still works, but it's just they require more often.
Right.
And more sessions, yes.
You go back to the bariatric surgery slide. Do you know what the average age of patients in that study were? I just curious if because if it, it's not like everyone that gets bariatric surgery is of childbearing age either.
If I remember correctly, the average age they said 35 plus. I see around 35 is where I.
So certainly not necessarily peak childbearing years. No. Certainly the possibility of pregnancy still exists, but lower likelihood. Mm-hmm. It's a small study. I was just.
It's a very
And what was the percentage of the weight loss that kind of helped that?
So yes. The percentage I can't recollect from the top of my head.
Something again we can use as a kind of argument when speak with the patient. So it's that when you set up an expectations for bariatric surgery, if I did have a patient who gone through bariatric surgery, with mixed results obviously, but I was curious if there is any percentage of weight loss that you would expect better outcomes as far as.
Yeah, that's something that I can look into and kind of get back.
The chart that has less and you can read it.
Are there any other studies looking at Ozempic, Mounjaro? Are they looking at?
And I haven't seen any, but I read something about a
Victos, I don't think there is.
Oh, this is the same.
So yeah.
Ongoing. There's their ongoing studies coming out where they're looking at because the Ozempic study says.
Last time we checked, Lilly was not interested in playing that game. So.
Okay.
They have a business already.
Well,
They don't need
they all,
extra
they all,
indications.
they don't
Yeah.
need other
They
indications.
don't need other indications. So it's a waste of money for them.
Yeah, that's fair.
So we have a chart. Thanks, Dr. Keating.
Only OCP. I think, so OCPs are FDA approved for PCOS. But
Only one is, I think.
yeah, but I think
There's
there's,
Paranol.
yeah,
I mean,
I think it's
but,
weird.
but I'm definitely not for
When I read about SLIND, which is the drospirenone, it's just branded or marketed as progestin only combined oral contraceptive pills, and it's not specifically for PCOS. I didn't see any evidence that. I mean, we had this conversation, but I went back and looked too, so I'm not sure. I might be wrong, but that's what I found. But it definitely has a significant anti-androgenic. Property. It's fourth generation, but also associated with VD risk. So to answer your question, I found that there was a 60% weight reduction. 60%. Yeah, thank you. So they started from 117 and they went down to like 70. So good weight loss.
Any other questions?
I just have maybe more of a comment. I think PCOS is sometimes difficult to manage because it's not a condition that's owned by like one specialty. Sometimes people are seen by derm, endocrine, OB/GYN, or sometimes by people who would manage weight. I'm just wondering, is there any like studies that show people are seen in like a multidisciplinary kind of PCOS clinic have better like satisfaction or outcomes? Maybe Mickey, like something at University of Wisconsin.
Yeah, I mean, everybody that went through that clinic seemed to leave, I would say, much more satisfied than, because they get bounced around between, to your point, the different clinics. I mean, I would say, derm is usually just dealing with the anti-androgens, and then they don't really monitor, I feel like, at least from what I'd seen. But so they had reproductive endocrinology, OB/GYN, endocrine, and then they also had a psychologist there as well. And I think that's the big piece, right? Because there's so much mental health that's associated with this, and then dietitian as well. So they hit it all, and it was interesting because they have it set up. I don't know, was it like 4 patients maybe a day, 3 or 4, and they would rotate them through. So all of the visits were in the same day, where they would kind of rotate through. It was very expensive, but I think it was nice because they would kind of convene back in between the visits and kind of discuss, what they learned kind of amongst and their plan kind of going through it, and then they did the labs. Because I think, to your point, Catherine, I would say I think do the best job of doing the additional exclusionary testing. I would say a lot of the other subspecialties are not doing the 17-OHP. They're not doing cortisol testing. They're not doing prolactin would be the other one that I would add in there too.
Yeah.
I don't know if it was in there or not, but they don't test for those, I think, as frequently.
For all the 17-hydroxy, I do it, but I'm just saying, for all the 17-hydroxy progesterones I've ordered in my lifetime, I haven't found a single one. But I know I ordered it looking, I'm just kind of making.
Yeah.
we still do it.
Yeah, I still do it for that one person we might miss in our lifetime.
Thank you.
Thank you.
Really comprehensive.
Be a good question for Dr. Hawkins. His end much larger. Right. I mean, obviously, he's going to have a higher proportion.
There's like questions that are